what we heard today is that the stigma and the weight bias that we've been talking about and the complexity of obesity they're both very difficult challenges that we have to tackle. I am a public health person. I have a PhD in public health, and this is the mantra that, the ecological model of health promotion that we use in our training. Basically, whenever you address a complex issue, you have to do it at multiple levels. And we're talking influencing, when we're talking about getting obesity recognized as a disease and reducing weight bias and stopping weight-based discrimination, we're talking about doing policy work, trying to address things and change the policy so that it is not okay for a primary care healthcare provider or an employer or the media to discriminate against a person because of their size. And then, in order to do these changes, we need a lot of people working together. So we need communities to build relationships like we're doing today at this workshop where we're talking about, what's France doing, what's the UK doing, what's Canada and the US doing. Like all of us are doing things, and I think we can learn from each other. And I think that's very important that we had this opportunity today to talk about that. But we also need to unite the organizations. And so the Canadian Obesity Network is a professional association that was started 10 years ago. But we realized very quickly that we need to work with patients as well as professionals. And so we do need to change health professional practice, and we train health professionals, and we develop tools, and we do weight bias sensitivity training, and we develop clinical practice guidelines, and we do research. But fundamentally what you have to realize that a lot of people who work in obesity have been trained in various disciplines. And the majority of people who work in obesity have been trained in either nutrition or exercise. And so these are the worlds and the lenses that they bring to obesity, right? Like they've been trained in these fields. And in public health particularly, my colleagues are dietitians, nutritionists, exercise physiologists, people who have been trained according to the energy in, energy out model of obesity. They still haven't been trained in the spaghetti model of obesity that Dr. Sharma showed. Many of my colleagues that are dietitians working in public health, or people who make public health policies in Canada, are dietitians, exercise people who have been trained in that energy in, energy out model. And so I think sometimes I felt like even when I talked about obesity before, I wasn't aware of what I didn't know. Right, so instead of pointing fingers at my colleagues in public health saying, I looked at all your policies and they're all biased, I took a lens of myself and said, I was trained like that. And so we need to change that narrative. So how do we change the public health narrative that obesity is not just about diet and exercise, that obesity is not a choice, obesity is not a self-inflicted disease, that obesity is much more complex, like Dr. Sharma was talking about. But I have to understand that they're like me. They were not trained on this. And so rather than pointing fingers at them and say, you guys are being very bad here because you're focusing on prevention and you're not doing a lot on treatment or supporting patients who have obesity, let's instead work together. And from an interpersonal level, I think, we all have people, we all know people who are affected by obesity. In my own family, I have many family members who have obesity, right? And so obesity affects everybody in society. It's not just the people who have obesity, it's people who work in obesity fields, it's people who work in public health, it's families, it's neighbors, it's everybody who has obesity is affected by the stigma that is experienced by people living with obesity. So in my own personal case, I have a nephew who has had bariatric surgery, and he was bullied as a child all his life. And this is why I'm very passionate about trying to deal with this issue, because I saw it affecting my family, right? And so public health policymakers, they also know people. And when I interviewed public health policymakers, many of them had obesity themselves, and they had experienced the weight-based bullying and shame, right? So I think it's just that we need to talk more about it. And at the individual level, the Canadian Obesity Network, we've changed the way that we function within our network from a professional network to being an organization whose mandate is entirely focused on improving the lives of Canadians living with obesity. And we recognized that we needed to change, and we needed to bring patients into the network and develop models that are user-driven, right, patient-driven. And so from CON's perspective, from the Canadian Obesity Network perspective, we've done multiple things to try to change the narrative in Canada, right? Like I showed you earlier this morning, the report card where we showed that there's a lot of focus on obesity prevention in children and youth, and no access to obesity treatment. And in part, that was because obesity is seen in Canada as a risk factor, not as a disease. And so we're trying to change that. But what we realized is we need the patient voice to be with us, to tell us, and to tell everybody else and educate everybody else that obesity is not a choice. Obesity is a disease. People do not choose to have obesity. People do not do this to themselves. And so we created the Public Engagement Committee a few years ago, but it's taking us 2 years to get to the point where we have a group of individuals who are ready and prepared to advocate for obesity, right? Like, so we went through a strategic planning session, we went through advocacy training, we finally have a public engagement coordinator inside the Canadian Obesity Network. It took 2 years to get to this point where we have been able to change our organizational structure and the way that we do business in the Canadian Obesity Network to be more patient-centered. And I think if CON can do it, if the Canadian Obesity Network can do it, everybody else can do it. It does take the commitment from the leaders like Dr. Sharma and our board of directors and everybody to say, yeah, this is the way that we want to go, and we can change. We can be more patient-centered. And then from our clinical practice guidelines, if we want to influence the behavior of practitioners at the primary care level or in hospitals, wherever we want to do, we do need more patient-centered clinical practice guidelines, right? Like, so it's not just physicians learning more about obesity or dietitians learning more about obesity. It's how do we work with the patients to develop a better therapeutic relationship between patients and healthcare professionals. And so the guidelines, and several of my colleagues, Denise and Mary and Dr. Sharma, are developing these guidelines, and we have patients on the steering committee for the clinical practice guidelines, because we want to make sure that these guidelines are patient-centered, and not only making sure that they have the patient voice, but also making sure that when we develop the final dissemination tools for the guidelines, we have patient tools. We have information and resources for patients that they can grab and take it to their professionals, to their doctors or nurses, and say, look, I got this from the Canadian Obesity Network. This is the clinical standard for obesity management. It can help them advocate for themselves, right? So we need to, I think it's possible. It's been working very well. It's taken, again, it's a 2-year process. We're kind of like midway through it, but patients, we have a patient on the steering committee. Patients are reviewing the research questions. Patients are reviewing the recommendations. Patients are developing the dissemination tools. It's an ingrained process. And then the action study, which, to date, we didn't really have national data on the prevalence of, weight bias in Canada, or national data on, how patients perceive access to care, or how healthcare professionals perceive access to care. And so thanks to Novo Nordisk, who funded this study in Canada, CON now is taking the results of that study and contextualizing them based on our experiences. And we can use those research results to continue to advocate for closing the gap between obesity care and the people's experiences. And then, like Mary talked about today, trying to influence how everything happens in hospital. So from the moment a patient walks into a hospital, into an ER, how do we create safe environments that Vicky's talking about, respectful environments where people feel like, it's not their fault, and that they're not a burden, that they're regular citizens that deserve equal treatment like everybody else. So from my perspective, I still think we need a lot more work in changing public health. And public health is obviously biased to me because I'm a public health person. But I think public health has a huge influence in what happens in obesity treatment. Because if we continue to talk about obesity prevention and ignore the fact that there are 6 million Canadians who have obesity already, what's happening with the 6 million people that obesity cannot be prevented in already because they already have it? So it's a social justice issue for me that we cannot continue to talk about public health and obesity solely focusing on obesity prevention and ignoring the fact that people are living with this disease and need help. And so after my PhD, Dr. Sharma had this awesome idea, which is, that this is what's very, very good to work with him. Because he came up and he's like, your PhD is really good, but we need to make it practical. Like, what does this mean? What does this mean for public health policymakers when they're developing a policy on obesity? What do they need to do? What do they need to think about to make sure that there's no unintended consequences in their language, and in their recommendations, and in their strategies? And so I came up with a few things that I think public health policymakers should ask themselves when they're developing an obesity strategy or an obesity policy. First of all, I think it's very important that we clarify that a healthy eating policy or an exercise policy is not an obesity strategy. And so if you're going to develop a healthy eating strategy for your province or whatever, ask yourself, is the goal to improve healthy eating, or is the goal to reduce obesity? Because if you continue to think about a healthy eating strategy as an obesity strategy, you're simplifying obesity as a diet issue. And you're continuing that narrative that people just eat too much, and that's why they have obesity. So I think the first question whenever policymakers sit down is this policy intended to promote health and well-being, or is it an obesity policy? Because if it's an obesity policy, it cannot be just about healthy eating. It cannot just be about exercise, right? It needs to be a comprehensive and address all those system level issues that Dr. Sharma identified in the assistance map and the spaghetti map, right? So having a healthy eating strategy doesn't mean you have an obesity strategy. And having an exercise strategy doesn't mean that you have an obesity strategy either. Obesity needs to be much more than that. The second question that I think people should talk about is, so a lot of our health promotion strategies are about changing healthy behaviors. My supervisor, Dr. Kim Rain, she focuses on changing the environment to make the easy choice a healthy choice. That's the thing. In health promotion, we want people to eat healthy and exercise, and we want the choices to be easy for everybody, which is a very, very good goal and very good objective. But that's not an obesity strategy. The whole population needs to eat healthy and exercise, right? It's not just people with obesity that need to exercise more and eat healthy, right? So whenever we do a health promotion strategy to change behaviors like sleep, exercise, and diet, that's not an obesity strategy either. That's to improve population health. That's to improve the health of everybody in Canada or in every country that we're working in, right? So labeling or positioning a healthy behavior strategy as an obesity strategy is also not helpful, right? It continues to bring that narrative again that obesity is about behaviors, individual behaviors, and we know that it's much more complex than individual behaviors. So I think we need to ask critically the question, are we using obesity as a hook to promote healthy eating? Are we using obesity as a hook to promote exercise, right? Would we do that with diabetes and say, oh, we're gonna prevent diabetes by just having everybody eat healthy and exercise? And we do that with obesity. Every single policy that I reviewed in Canada that called itself an obesity policy was really a health behavior change policy, an eating healthy policy, a diet, an exercise policy. So the question is, if it is a health promotion strategy, do you even need to mention obesity? It's probably not about obesity, right? Question 3, is this an obesity prevention reduction policy, and what are the goals? And so if it is an obesity strategy, are we measuring the success of our strategies just on BMI? Is your goal to change BMI at the population level, or is your goal to improve the health of Canadians living with obesity? And if that's the case, then we need to have broader outcomes rather than just BMI, right? We need to measure the health of individuals living with obesity. Are they healthier? Are the quality of life? Do they have less pain? Whatever. There's other outcomes that we can measure other than BMI or weight. Question 4 is this policy creating unintended consequences, such as labeling individuals according to their body size? So in public health, we have the categories of healthy weight versus unhealthy weight, and we love that term. But really, what is a healthy weight and what is an unhealthy weight? It's different for everybody. So we cannot categorize groups of populations according to be healthy just based on their BMI. Because Dr. Sharma explained, you could have a BMI that's normal and has obesity-related comorbidities, and you could have somebody who has a BMI that is high and doesn't have any comorbidities or any health issues whatsoever. So categorizing people to be healthy according to their BMI or their body size is not helpful either. So we need to question that in our policies. And are we using person-first language like Joe was talking about, like are we, talking about obesity as a chronic disease as opposed to saying obese people need to eat healthy? No, everybody needs to eat healthy, and people with obesity as well. Question 5 finally is, have you engaged persons with obesity in the development of this policy? And this is what we've been talking about in the whole workshop about, okay, how do we make sure that public health policies are actually people-centered, right? It's not just us sitting in our own offices developing public health policies and thinking we're going to improve population health by talking to ourselves about what needs to change. Well, if you're doing an obesity strategy, why not talk to people with obesity about it and ask them, what should this strategy be about and what should we talk about, right? And so have you considered the impact of this policy on persons living with obesity? Like, these are questions that I think are like key, and I'm hoping that Dr. Sharma, who's sitting in the back, is thinking, yeah, that's more practical, but I don't know. Thank you.